Okay, so let's make a start. So advanced MRI of the knee. So let's go. Okay, so essentially today I want to cover some of the MRI essentials and protocols. It's stuff that you should be familiar with. There's nothing new on here. A lot of the time we're just looking at either fat weighted or fluid weighted. There are one or two special sequences, but as I said, I just tend to stick to the basics. We want to look at some normal anatomy, and then I'm going to go through ligamentous injuries, meniscal injuries, cartilage and osteochondral lesions, a little bit of the bone and the marrow pathology. We'll look at some soft tissue stuff, and then we'll look at a way of reporting, giving you a little bit of structure, because the knee can sometimes, each of the areas of the body sometimes need just a slight variation in terms of how you structure your assessment and your report on them. So essentially, when we do an MRI, we have the person supine, we flex the knee to 10 to 15 degrees so we get a really good view down the notch. The coil, we use a dedicated knee coil to get the images. And then the sequences, we're looking at the standard sagittal, coronal, and axial. And a lot of the time we're using the PD fat sats is some of our most common ones. And you'll see that is the majority of the images that I've used to show you stuff today. And failing that, we're looking at the T2 weighted, and we're looking at the stir, because a lot of the stuff we're looking for edema, we're looking for swelling, we're looking for fluid. So a lot of the pathology around the knee is fluid based. So that is why we tend to go towards the fluid weighted type images. There are other options that you have in terms of 3D isotropic. We can look at the T1s, post-contrast if we're worried about infection or tumor. But as I said, we have covered these before, and a lot of the standard stuff that you will see in clinic, we're not going to need any of these special things. But it is nice to know that if you're looking for something specific, speak to your friendly radiologist, and I'm sure they'll have a particular way of showing you what you're looking for. Okay. So there are a few artifacts that come along. So we've got the magic angle, which is the 55 degrees to the tendon, which interferes with some of the views a little bit. We sometimes get partial volume, which is when we're looking specifically at the meniscal roots. We just don't get a very good image sometimes, and we've got to readjust how we're actually sequencing items. And then again, if the person's had any surgery, they've got any metal artifacts in there, particularly if they've had reconstruction, so reconstruction of the ACL or the PCL. We now use MRI-friendly screws and anchors, but sometimes it does cast a shadow if we're not using the specific metal artifact sequences. So again, safety rules apply. You need to make sure that the person's safe to enter into the MRI room, and also safe to enter into the MRI scanner. If we've got a highly metallic object, if it's magnetic, it is going to fly through whatever it is in and attach itself to the MRI scanner. So if that implant is rooted in bone, it doesn't matter how firmly it's fixed, it doesn't matter if it's in bone, it will go through whatever it is to make its way to the MRI scanner. So it can cause huge amounts of damage and injury. So this is why you need to make sure people are safe. And then use of contrast, again, if we're looking at tumor, we're looking at infection, we're looking at post-surgical scar. Contrast gives us a lot of those answers, gives us great images, but we've got to be aware that it can sit in the person's kidneys. If a person's got kidney problems or poor renal clearance, that gadolinium will just sit in the kidneys and essentially cause a lot of local irritation and some damage to the kidney. So we want to be sure if we're going to be using any contrast, that they have the ability to get rid of that contrast out the kidneys. So just make sure you ask the questions before you ask for the gadolinium. Okay, so quick anatomy review. I'm sure you guys are all familiar with the bones. We've got the femur, the tibia, the patella, and the fibula. Not like the junior doctor who was on the phone to me a couple of weeks ago, who spoke to me about the tibula. And I was just like, I'm not familiar with a bone called the tibula. So just remember, it's a fibula tibia. I'm sure you know that. Cartilage, it's normally smooth, it's uniform. If we've got any irregularities, that's normally a sign of pathology. Menisci are wedge-shaped when we look at them, and that's because it's a horseshoe towards the center. It's very thin, and then it thickens out. So you get these wedges, and then obviously as we're cutting slices, you're going to see parts of those wedges in different amounts of profile. Ligaments, we've got the lateral and the medial collateral ligaments, and then you've got your cruciates, your anterior and your posterior. And then you've got your extensor mechanism. So remember, your extensor mechanism is your quadriceps. You've got a really thick fascial tendon that then comes along, and it's essentially from the quadriceps, it's continuous all the way down to where it inserts in the tibial tubercle, except it encases the patella. So your patella is essentially a massive sesamoid bone with a layer of tendon going on top of it and a layer of tendon ligaments going on top of it and below it, and then it's actually attaching, as your tendon does, into the tibial tuberosity. So if you actually do surgery on it and you look at the anatomy, you can see it's just a continuous sheath. But for the sake of talking about it and for the sake of diagnostics, we divide that up into the quadriceps tendon, which is proximal to the patella, and the patella tendon, which is distal to the patella. And then we've got the soft tissues that we need to keep our eyes on. So we've got various fat pads, we've got various bursas, and the synovium is really important because there's a pathology that happens with the synovium that we'll talk about, but also you get little plica, you can get irritation on the synovium can become inflamed, and it's very painful for the person who experiences that. Okay, so femur, distal femoral condyles, really important. Trochlear groove, your patella has to sit in the trochlear groove, and your trochlear groove is very important because your patella, the undersurface of the patella is actually V-shaped. And if you think of the trochlea as being like that groove between my knuckles, the patella sits in there and essentially slides up and down. So if you've got maltracking of that patella and it's sliding to the side, you're going to get a lot of uneven tension. You're going to get a lot of uneven pressure on the cartilage. And one thing cartilage does not deal well with is uneven pressures across its surface, because that is what promotes degeneration, and that is what essentially brings on the arthritic changes that we see. We've got cortical bone that we need to look at, and then we've got our marrow as well that we'd be looking for in terms of any changes. Tibia, we've got the two tibial plateaus, medial and lateral articular surfaces. We've got the tibial spine that is on the superior surface, and then we've also got our tibial tuberosity that we need for some of our measurements that we do, particularly if we're looking at patella tracking. Patella, it's a sesamoid bone, as I've said, because it's encased in the tendon, in the quadriceps tendon that comes down. It's triangular on the undersurface because it sits onto the trochlea, which is the grooves in between the femoral condyles. And the cartilage is one of the thickest areas, is where your cartilage is in the knee. So your patellofemoral joint is very, very important, particularly from an arthritis point of view. And then the fibula is considered part of the knee joint, even though it doesn't actually articulate with the femur. It actually is quite a movable joint. When you look at the mechanics, your fibula actually rotates quite a bit. It's attached partly to the lateral collateral ligamentous complex, and you've got your various fibular ligaments that attach there as well. So if someone is having lateral ligament pain, if someone does have a lateral ligament injury, don't forget you've got those ligamentous attachments with the fibula as well. And it's really important to look at the fibula head for a number of reasons. One, for those attachments, also because you can get a subluxation and a dislocation of the fibula head. And also if the person has had an ankle injury, we do sometimes get ankle injuries. It's called a Weber C or a Mason nerve injury, where the force comes across the ankle joints, travels up the syndesmosis between the tibia and the fibula, and then exits out the fibular neck really high up. So sometimes someone can have an ankle injury and you don't really pay a huge amount of attention because it doesn't look very dramatic at the ankle, but people forget to examine the knee and they miss the injury at the knee. So always make sure you look at the fibular head. And the MRI relevance was really that we're looking at the bone marrow because we're looking for edema, either because we've just got a stress fracture, a stress reaction, we've had some kind of impact to the bone and all we can see is the edema. Sometimes we get subtle fractures that are not really visible, and we're using the MRI to look up something that clinically sounds like a fracture, but we're just not seeing it on the other imaging that we got. We're looking for that cortical continuity again for the same reason, and we can see our trabecular architecture really, really well. So MRI for the knee, if we've got some of those more subtle injuries, fabulous, absolutely fabulous. Cartilage, nice and smooth and uniform. We've got the articular cartilage that is both on the femoral condyles and on the tibial plateau. It's normally an intermediate to high signal on on PD or T2 fat suppressed images. Now the thickness varies. It really depends where you're looking at as to how thick that is. So just because you see thinning of the cartilage, you have to orientate yourself as to where you are on that articular surface as to whether you would expect the cartilage to be thick and it's thinner because of degenerative changes, or it just naturally is a place where that cartilage is thin. So it's thickest at the patellofemoral joints and it's thinnest medially. Normally, it appears smooth, it's uniform in contour, and you don't get any irregularity or fissuring. And sometimes it can be quite deceptive because you look at it and it looks smooth. Even if I'm doing a scope, I can look at that and it looks pretty smooth. And then I get like a little blunt hook and I can flick around any areas. And sometimes you get these little flaps that come up, but sometimes it can fool you. So you are looking for those subtle changes. There's an outer bridge classification that we use when we're looking at cartilage degeneration. So 1 is where we've got a signal change, but the surface is intact. 2 is where we have a less than 50% defect. So if you're looking at the thickness of the cartilage, that defect leaves 50% of that cartilage before you actually reach the bone. 3 is when you're past that 50% mark, but you still have some cartilage protecting the bone from communicating with the open space. And 4 is when you've got a full thickness defect. And as I said, sometimes on the scanning, we think we've got a grade 2 or we've got a grade 3. Actually, on the scope, we flick it with that hook and you can actually feel that we're down to bone. So sometimes it can be a little deceptive. Now, the reason we MRI this is because we want to look for focal thickening, we're looking for delamination, and we're looking for that subchondral bone reaction, because sometimes that subchondral bone reaction tells us more of a story than any other imaging that we've got. Okay, menisci, they're wedge-shaped because we've got the horn, thickest on the outside, thin towards the center, and then if we're cutting them in a coronal, you're going to get a wedge and a wedge because you've obviously got nothing in the middle because it's a donut or a horseshoe shape. Your medial meniscus is C-shaped, it's less mobile, and it's really anchored to the MCL. And the clinical relevance of this is that if you have an MCL injury, you are going to injure that medial meniscus. So the two kind of go together. And if someone hasn't got a medial meniscus injury with an MCL, either one, you're misdiagnosing the problem and they don't have an MCL injury, or they are incredibly, incredibly lucky. Okay, lateral meniscus, it's more circular, it's more mobile, it's a lot more forgiving with injuries. But if we do get a tear in that lateral aspect, it's really annoying. It's very difficult to settle down for the person who's suffering from that. And then we've got our roots. So the roots are the anterior and posterior horns where it comes through and it anchors down. We've got meniscotibial and meniscofemoral ligaments that come through there that anchor it. So if we've got a horn injury or a root avulsion, it's a very, very significant injury. It often needs surgery, and even with surgery, the ongoing consequences for that can be pretty devastating. So it's not something that we really used to recognize much 15, 20 years ago, but with the advent of imaging and a better understanding of the knee and the mechanics, we're now starting to recognize these femoral meniscotibial ligament injuries, the separation injuries, and then these avulsions and these root extrusions. So if you see something with a meniscal extrusion or a root tear, it's a very, very significant injury, and they do need to see someone for a surgical opinion. They may not get surgery, but it's good for them to have that discussion. Okay, and what we're specifically looking at, the big one on the MRI is a double PCL sign, and it looks like you've got two PCLs, and that's classic bucket handle tear. So beautiful exam question. It's a picture, you can't miss it. You see that picture, you know exactly what it is, marks in the bag. So don't forget about that one. Okay, and then just to remind you guys about your meniscus. So we've got the C shape on the medial side. We've got the more circular one on the lateral side. These are your horns over here, front and back. And then you've got, it's not really shown on here, but you've got ligamentous complexes front and back. And if you get tears through here, and separations through the back, and this extrudes because you've then got a very hypermobile meniscus. As I said, horrible injury, really, really horrible. So you need to be aware of that. Ligaments, we've got the cruciates, anterior and posterior cruciates, and then your medial and lateral collaterals. Again, your cruciate injuries, I'm sure you know lots about them. Anterior, posterior, we're going to talk through them a little bit more. Essentially very important for the stability of the knee. So it's the anterior posterior movement that your ACL and PCL are going to help you with. And potentially if people are needing to pivot or turn corners, so sports people changing direction very quickly, you need to have that inherent stability in the knee. But it's that exact changing of directions that puts sports people at risk, or just anyone at risk of actually having a cruciate injury, a cruciate ligament injury. Medial collateral, lateral collateral, it's more sort of your varus valgus stresses. So if you have someone impact say, we're talking about my right knee, someone runs into the side of me, my knee then goes into valgus. So my knee collapses towards the other knee, and then I end up with a sprain on the medial collateral ligament because my knee is bending. If that's my knee, someone gets hit from the outside, it bends that way. It's the medial aspect of the knee that gets injured. If it goes the other way, so I'm planted my foot, someone hits the inside of my knee and it goes to varus, it's the outside that's going to be sprained. So it's fairly logical if you think about it. Gets a little bit more complicated if someone's pivoting, someone's twisting, or they're not entirely sure what's happened. And don't forget, we can often have combinations of ligamentous injury. So it's really important to recognize if you've got an ACL injury, there's likely to be other injuries that you need to be aware of. The same with the PCL, MCL, LCL. We'll come to some of those combinations a little later. Okay. So essentially the MRI, you're looking for fiber discontinuity, you're looking for edema, and you're looking for secondary signs of instability. Sometimes it's not that clear. And sometimes you'll look at the ligament and go, I think there's still a few fibers that are intact. And sometimes the way they slice the images, you may not get the exact slice that shows you that it's fully separated. But this is where you're going on the clinical exam, you're going on what you can see, and you're going on all those other signs as well. So hopefully it's fairly diagnostic that you can see it, but it's not always the case. So always bear that in mind, that you've got to come back to the clinical picture, you've got to come back to the history. Okay. And I've just put up a nice little diagram. It's nice and simple. It just reminds me of the structures that we're dealing with. It's all nicely labeled, and you guys can go back and use that for your reference. So I know it is very simple, but it's one of my favorite diagrams. So hopefully you like it too, for just refreshing your memory. Okay, and then your extensor mechanism we've spoken about. Quadriceps goes down, it encases the patella, which is essentially a big sesamoid bone. You then go onto your tibial tendon, and then that goes onto your tibial tuberosity. Quadriceps tendon, you've got your 3 layers, and that comes from the different components of your quadriceps. So from your rectus, vastus, intermedialis, lateralis, and medialis, coming all the way down. Your patella essentially acts as a fulcrum. So essentially it's like a big pulley. It's a way of distributing the weight so that as the actual quadriceps contracts, it then distributes the weight and allows you to have that movement because it's concentrating the forces so that you get more efficient use of the energy. The patella tendon is from the patella apex down to the tibial tibial tubercle or the tuberosity. It's approximately 25 to 30 millimeters long. There are lots of measurements with patella alta, patella baja, which is where the patella is sitting high, the patella is sitting low. These have consequences with regards people dislocating the patella or having injuries, but I'm not going to go through that because that's more of a diagnostics sort of lesson that we have there. So you may get someone ask you, is this a patella alta? Is this a patella baja? There are specific measurements and different gradings. So there's the Blackburn-Peel ratio. There's various other ratios. I'm not going to expect you to know that. But just be aware that you can have different positions of the patella for various reasons, and that can influence the patella stability and put the person at risk of patella. Normally it's a lateral dislocation that they have, and along with that you come with a MPFL or a medial femoral patellar ligament injury, and then it just is prone to ongoing dislocation from there. Tibial tubercle, important to know, you can feel it. It's the insertion of the patellar tendons. Sometimes you can get pathology there as well, can be sore. So particularly things like your Osgood Schlatters. Again, I'm not going to cover that in the session, but again, just read up on it. It's more of a diagnostic sort of thing, but it's good to have in your mind where the anatomy comes, where the tuberosity is, where the tubercle is, so that if you have suspicions, you can always identify exactly what you're looking for to make up your diagnostics. Okay. Soft tissue, fat pads versus synovium. Your fat pad, you've got your Hoffer's fat pad, which is at the bottom end of the patella and at the super and at the top end of the patella. It's normally bright because it's fat, so it's bright on your T1. It's variable on T2 depending on any pathology that's there, and it can impinge. So it is a source of pain if people have knee issues. There's various bursa around the knee. So again, your bursa is your folds of synovium, and that essentially is a lubrication way. It's a way of everything, of structures moving over each other, reducing the friction and the irritation. And then your synovium is thin, smooth, thickening. With enhancement, you get synovitis, which is inflammation of the synovium. You get what we call this blooming, which if you look on the scope, it looks like almost like bits of algae, sort of clumpy algae, and it can be quite inflamed. It can be red. It's sort of like a dark maroon kind of color. And this is often something we get we call it PVNS, which is pigmented villonodular cyanosis. So have a look at that, PVNS. In some cases, it's a benign condition. It affects the synovium. What we do is we go in and we basically just shave it away. It does come back. With some people, it can be quite aggressive. It bleeds quite a lot. And if we get PVNS, it can affect tendons as well. You can also sometimes get it in the hand, and that's called a giant cell tumor of the hand. We can get, it's a tendon sheath. Giant cell tumor is actually PVNS. MRI is really used to evaluate for effusion. We're looking for plica. We're looking for cystic changes. So again, a lot of fluid-based pathology that we're looking for. And it's really important to look for it because you can have bursitis, which is where we can see where the bursas are anatomically become filled with fluid. Any of your inflammatory arthropathies, you'll end up with fluid-based pathology, or you get the PVNS. And I've got a really nice slide I can show you what it looks like.